pleasure and honor to be here today to talk about the elbow joint. And I want to congratulate the organization with this fantastic symposium or congress. Some disclosure. Well, we're talking about arthroscopy of the elbow joint. What are the possibilities? What are the pitfalls of arthroscopy? Why is it an issue? Because we all know the proximity of the neurovascular structures are an issue. It's a very complex articulation. You got a very small space to work in, and that's interesting. And finally, it's difficult to gain experience. I want to look at, for example, the PubMed on arthroscopy and knee, more than 8,000, arthroscopy and elbow, more than 700. So it's just a niche market. Complications, is it an issue? Yes, it is. We did a study a couple of years ago, and we saw 5% complications in the first 200 arthroscopies. And interesting, there was no significant relation between the complication and smoking or patient characters whatsoever. But we did see some serious complications like neurological damage. This is a study from last year. It was a global study of the Netherlands, and it was based on the information of the insurance company. And last 10 years we had 8 cases in the Netherlands of complete nerve injury, so it's important to realize. And most of them were about the ulnar nerve. So the ulnar nerve is really the structure at risk, and we heard it this morning in a nice lecture on stiff elbow. So why are we doing arthroscopy? Is it dangerous, and are we going to end up like this? Well, of course, it's got some advantages, you all know. It's got small incisions, you've got a perfect view of the joint, it's a faster rehab in general, small scars, and finally, it's fancy, it's sexy to do arthroscopy. What are the traditional indications? Of course, we know loose bodies, synovectomy, rheumatoid arthritis, osteophytes, contracture release, lateral epicondylitis, the OCDs, classical indications. And then we have some what we called evolving indications. It's on instability, duplication of the postlateral compartment. Elbow trauma, I think if you're an arthroscopist, most of you have some experience with radial fracture. We'll have a lecture of it after my lectures. Some unicondylar humeral fractures can be done by arthroscopy, coronoid fractures, and sometimes you can do osteoma, although I tried it twice, but it's very difficult to see. What you cannot do with arthroscopy is reconstruction on the medial side, MCL, transposition of the ulnar nerve, that's technically not possible by arthroscopy. Of course, arthroplasty is not possible, and complex open reduction tunnel fixation or fractures. I won't go over the ulnar nerve. I think that's not arthroscopy, endoscopy, and there's a very nice lecture on that topic tomorrow. And I won't go over a distal biceps pathology because that is a bursoscopy. It's an endoscopic procedure as well. Do we have any evidence? Are we allowed to do arthroscopy of the elbow anyhow? If you have some complications, well, you have to look very carefully. Are we allowed to do arthroscopy? Well, yes, for most indications, for the classical indications, there is evidence to support the procedure, but the quality of evidence is poor. We have to realize it every time again. So what are the limitations, and what are the pitfalls of arthroscopy? And I would like to go over with you with the 4 most common indications, at least in the Netherlands. And finally, I want to congratulate you and wish you all the success in the football competition coming up, the European Champions League, because we are not playing there, as you know, and of course, whole Netherlands are for Germany. And that's the first time of the last 10 years. Oh well, we're talking about stiff elbow. Stiff elbow, in the past we did an open procedure for that, and the average OR time was 35 minutes. I was a little younger, as you can see, and the results were quite alright. So it was stiff elbow, lateral column procedure, easy procedure with a good predictable outcomes, no complications, and a fast and easy, a relatively easy procedure. Of course, everybody starts to do arthroscopy, so did I. That was 10 years ago, and we started with arthroscopic release of stiff elbow, and actually I was very satisfied with the procedure, with a lovely overview. However, I was a little bit disappointed that the increase in range of motion were more or less the same. So my results, arthroscopic stiff elbow, are the same as open procedures in my hands. However, the OR time is much more, it's longer, and my residents don't like it because this is technical demanding, and my residents want, of course, to do procedures they can handle themselves. So we have to realize that. If you look in the literature, the results after arthroscopic contracture release are really good predictable results. There's still not a real evidence that's better than open procedures, although the rehab might be a little longer, especially in the first 6 weeks. With the contraindications, so cases in which you should not do arthroscopic procedures. And the first one is focus on the ulnar nerve. As in my introduction, I showed you that the major structure at risk is the ulnar nerve. And if you don't know where it is, for example, after a transposition or multiple surgery, you first have to identify the nerve and then do your arthroscopic procedure, or you do an open procedure. Very stiff elbows, because the content of the joint will be very small and it will be difficult to get in. Severe joint irregularities, you can imagine that the release of this stiff elbow is not useful. And of course multiple surgeries, because all the scars will change the local anatomy and will increase the number of complications. Is there any evidence for arthroscopic debridement of primary osteoarthritis? And there's a very nice systematic review in this. And they say that it's based on the surgeon experience. So please realize that, of course, I really like arthroscopy, but there's nothing wrong with open surgery. The second thing, a Dutch experience I would like to share with you is an OCD. I think you're all familiar with that. Recently we did a nice mapping study on the OCD, CT based, and you can imagine that if you want to perform open surgery for OCDs, it is a difficult area to assess. And why is that? Because we do our surgery in flexion. So if you do open procedures, you know that the LCL will be overlying this part of the OCD, and in most cases you have to release the LCL. So I think OCD is the perfect indication to do by arthroscopy. However, if we look at our own cases, we've seen quite a lot of redos in our clinic, and I show you why that is an issue. Because the OCD will be difficult to assess during surgery. Look at this girl, she's a volleyball player, 15 years old. She has had arthroscopy by 4 portals, 2 anteriorly, 2 posteriorly. She still complains. This is the X-ray after the primary arthroscopy, and this is CT scan. So you can actually see that the OCD is still there. You can imagine if you do arthroscopy in flexion that the radial head is covering the OCD, so it might be difficult to assess. And that's what I would like to stress. If you perform arthroscopy for OCD, you need at least 6 portals, and you have to working portal on the lateral side. Of course, you debride, remove all loose bodies, and then you use your ice pick after the curé, and finally you end up with an area like this. I would like to stress that you need at least 2 portals on the posterolateral compartment to have a proper overview of this OCD. And that's the most common complication actually in my country, is insufficient treatment of the OCDs. We did it in this way for a couple of years, and then we did an assessment of our own OCDs. And we have a group of 74 patients with a 90% follow-up rate and an average follow-up of 37 months. And one of the most important conclusions in the Netherlands on OCD is the time from onset of the symptoms to visit of the doctor is 20 months, so that's a shame. So actually the biggest complication of OCD right now is a doctor's delay, at least in the Netherlands. So if you have a young guy, most of them are young, 16 years on average. If you get a young guy with lateral sided elbow pain, it's an OCD until proven otherwise. That's important to realize. But we performed surgery on all of them, and we feel comfortable with that procedure I just showed you. However, after 3.5 years on average, 65% is still symptomatic. 55% return to the pre-injury level of sports. All of them are sports guys. So that's the conclusion, and we just have submitted this paper, is that actually the results of OCD treatment is not that good. And the return to sports, it's often career ending. It's very important to realize, and that makes us what is important for us in Western Europe is that we are really going to work on prevention. OCD should not happen anymore. We have to think about rules. Okay, back to arthroscopy again. Next topic is tennis elbow. And I first like to stress, we don't do that many surgery on tennis elbow because, of course, we've got the natural history and we start with injection therapy. Open or arthroscopy. The advantage of open procedure, it's an easy procedure. You can do it local regional anesthesia. It can be done by the resident. I can have some coffee. That really is One of the advantages of tennis elbow. Again, we first always start with injection therapy. Corticosteroids are forbidden in my country because of a national guideline. ESBT and Botox, there's no evidence for that. So we use at the moment autologous blood for injection, and we have some studies on that, and I would like to show you one slide on injection therapy, because how are you going to inject? We did in a last course in Utrecht, and we asked experienced upper limb surgeon to inject tennis elbow, and 60% was localized intra-articular, and just 1/3 of the injections was in the right place. So please be aware that injection is a very precarious thing, and we currently use a special device for very precise and good injection. So, but if injection therapy doesn't work, we think about surgery, arthroscopy or open surgery. What's the indication to do it by arthroscopy? If we have articular pathology as well, is it an issue? Well, up to 60% of all tennis elbow who need surgery have articular pathology as well. Like synovitis, bone spurs, loose bodies, degeneration. So that's important to realize. And that, if you have associated pathology, is a very good reason to do the ECRB release by arthroscopy. I won't bother you with all those videos. You can see them on ViewMedi. But I would like to show you something to prevent complications, because one of the pitfalls of the ECRB release, although it's a relatively simple arthroscopic procedure, is the instability, insufficiency of the LCL by your surgery. And think about the equator. If you equator the radial head during surgery, you know that you have to be anteriorly for debridement of the ECRB, and then you will protect the LCL. It's important to realize. And again, currently, arthroscopic debridement of ECRB offers a small but not insignificant improvement. So you can do it opener by arthroscopy, and the rehab is a little faster. Finally, I go very shortly over fracture, because the next speaker is going to talk about fractures. I think most of you will have experience by the fixation of the radial head fractures, but I would like to stress we did an MRI study on radial head fractures, and we see associated injuries, associated lesions, especially of the lateral ligament, and that's why I do my type 2 and the community type 3, I do them open. And that is because I can address the avulsed LCL pathology as well. So I started with arthroscopy, and now type 2, yes, that might be a good indication, unless there's an LCL injury as well, and then I do an open procedure. So in conclusion, yes, there's evidence to do arthroscopy, and I'm glad for that. Some indications to do not arthroscopy, and it's about the ulnar nerve, very stiff elbow of very irregular joints. If you're talking about OCD, I think there's no place for open surgery. It's very difficult to reach it properly. You need at least 6 portals, and think about a doctor's delay. ECRB, if you get associated pathology, that's a perfect case for arthroscopy. And please think about the fact you're choosing or to have wet feet or to have some coffee, and there's nothing wrong with open surgery. If you do less than 5 cases a year, please take the telephone instead of the knife and refer your cases to an experienced arthroscopist. Thank you very much.